Really happy to be here and among all the distinguished speaker in the webinar. As Maria mentioned earlier, I will be sharing mostly from my experience from the work I've been doing at Urban Studies Lab, which is an independent research center that I co-found with some of my friends from different universities and well from other sector like private consultancy or education as well. Today I'm will be sharing the work, which is I think is the nexus between using data, community building, stakeholder engagement, both from local and central government that lead to more inclusive, more attentive public policies for the local. So I think from the scale, comparing to the previous two speaker, it will be much more like on the ground. I hope you all are with me together. So a bit more about USL. This is to streamline what we are doing. We build partnerships with bottom up first, so in the local communities, but also with the government sectors, both like district office, if it in the Bangkok context, as well as the different department from BMA and other functional agency as well. We also work with private sector and international organization so that we can transform data and need from the or pain point from the local community to create place-based and policy solution that improve the life and creating lasting impact in the cities. This is our theory of change with the vision to build the cities and community where our people can live a good life. The main impact we want to drive is through 4P. The first one is policies. We use data so that the policy from the government can be more targeted, especially for the most vulnerable population. For the process, we are transforming planning and engagement to community-driven design, especially the investment into the local area. The third one is people. We are academic, we are teachers, so we love to incubate, we love to support agent of change, especially like our student, local community leader, government officer, so that they can drive more impactful ecosystem themselves. And lastly, is touch upon place. It's really important how we can translate the policy into the ground level. And I think place, especially in the neighborhood level, is super important. So for example, if we talk about policy, these are some of the projects we work. We use data to find the vulnerable house, both in terms of physical setting, like this rundown condition, but also their household condition. Two elder living together, one elder population living with bedridden, another elder, sometimes like 7 elder living together. Last year, we find this most urgent rate, like 30 of them, and we combine with government funding to help renovate the house to be more from the substandard or unsafe environment to more decent living environment. This is highly related to the life of the people living in there. And so for the process, we are working with different NGOs, non-profit and non-government organizations to work with local stakeholders, ranging from primary school student or like kindergarten to elder population to take ownership of the place they live in and also like make change and make difference in the local communities. Today webinar is from the Host Health City Network, and we'll be talking about climate change and resilience in urban planning. So just the disclaimer here, this is the angle I'm talking about when my background is more on disaster risk reduction. So when we talk about climate change, I look at the city and urban community in terms of vulnerability and risk. And if we talk about climate change, there are many climate sensitive health risks. And I will share with you some of the example of the initiative we take that into account. WHO also proposes operational framework to build more climate resilient and low carbon sustainable health system. You can see that the building blocks are quite integrated in the public policy, urban planning, but also like data, service delivery, as well as health policies. And it's drive, I think, if we talk about delivering the positive impact to the local community, what we dream ideally to deliver is so that they can have better health by themselves. So the first project is what we did during COVID pandemic, 2020, 2021. So right before Thailand went into lockdown for the first time. Because I work, at USL, we also work in the resource center called Fort Resort Engagement Center, where we host so many nonprofit organizations. And one of them, they work a lot with the vulnerable population. So the guys that come to talk to me and asking if we're gonna build a project to help local people, vulnerable population, where should he go? I think that not too surprisingly, I could not answer him where is the most vulnerable population or most vulnerable community in terms of COVID or pandemic risk. And unfortunately, Thai government back then also they didn't have a really robust data system to really pinpoint the risk area. So as a researcher, and I have the research team, so we start gathering data mostly from secondary source, from the census, from national census, from economic studies, and from other studies. We start with the hypothesis that the more vulnerable would be the poor families and elder population, because if they contact COVID, it can be fatal for them. So we just start with those two data. And we could find the granular level of data of 177 sub-districts. Normally, BMA is divided into 50 districts, but also our data is more granular than that. So from those two layer, we could know where are the sub-districts which is most vulnerable. Then we work with the primary healthcare unit. It's a public health center. In Bangkok, we have 50 districts, but we have we disperse and decentralize the primary healthcare more. Now we have 69 public health center. In each center, they work with local health volunteer. One local health volunteer normally takes care of 10 to 30 vulnerable families or households. So this is really important because the data we have is only in the sub-district level. When we want to go and help the local families, we don't know who they are anyway. So the connection to the local network, the public health center, and the public health volunteer is really important. So we can be more optimal. We know we make decision faster which area we need to go first. But after that, we connect to the local network so that we can redistribute. The model is not just about using data. We do the co-funding. We did the crowdfunding platform through social giver. We could raise around 5 million baht, and at the end of the project, we distribute more than 1 million meal, account for 50,000 vulnerable families throughout the process. And if you see in the map to the left here, throughout the process, because we connect to the local health volunteer, we could add up more depth, the layer of the data. We did add the Gini coefficient to see the wealth gap. We did add the population density. We did add the squatter and high density community, so far and so on. And we use that in the AHP in GIS program to subdivide the district into 7 levels of vulnerabilities. So from that, what we learned is that there's still limitation of data set, because if we rely on that only, we will miss out so many unregistered communities. In Bangkok, there are 2,048 local community which is registered under BMA, but there are many illegal community that did not meet the requirement to register as well. But because we connect to the local network, many local network point us to them. So this is, I think, the balance between using government data or secondary or top-down data combining with primary data, which is from the local community or stakeholder. And we can't take 1 year or 2 years to research and do the work, because it's during crisis time. So that we need optimal process and public to do intervention during that crisis as well. And we did the proof of concept first. So we did in one health center 20 in Pongpisit district in the inner part of Bangkok, because we have collaboration with them before. So it's easier for us to scale because we proved that model already. Otherwise, it would be really hard to work with other. And I think what's really important that we learn is that I don't think the vulnerability is in the local people. It's systematic. The way the way the government use data, and actually in Thailand, what really strong already is the social infrastructure, the local health volunteer, the community networks. So my work since then is at USL is how we can institutionalize community-led response system to do so. For example, this is the map on the left-hand side. You will see that this is the map that the health volunteer collect the health data from each household. We just help digitize them, and we can like make a risk map. We see which house has the elder population. We see which house has a concentration of symptom or like non-communicable disease like NCD. We also can plan for emergency route for the families or household that is have the bedridden member, and we also incubate them. We transfer it back to the local community. So on the right hand side is the risk map that we make with the local community, and we work and we learn with them how they can navigate and manage during crisis time if something happen. Because of COVID release, Bangkok, we got invited by PMUA, the project management unit for area-based development under Ministry of Higher Education, to lead the project called Urban Poverty Elevation in Bangkok. So same thinking, similar contract to COVID relief, but change the COVID vulnerability into multi-dimensional poverty. We collect 40 factors of data with the local network. This is a health volunteer. So from that 40 factors, we can put the poor family into spectrum from like very poor to like more well off. From that data that we have also helped connect them to the support that they need. The more like at risk can be like poverty card, for example, that provide them stipend. The more well off is job matching, for example, or vocational training. For that project, we did a 19 evaluation project, and the return of investment is around 9.9 on average, and we could stimulate almost 7.4 million baht in the economic impact in the local 3 district. We also help renew the process of housing renovation that we find the most vulnerable, and we find the gridlock in the government system that would not allow the poor family to be able to renovate because it take a long time of the process. When we intervene through the new system, we make the audit system so that it go faster. They can just use mobile application to audit the house, and then the district office can help validate. The outcome is that it's around 6 times faster than the normal process. So sometimes it takes years. Now we can reduce to around 1 to 2 months until they get the money to fix the house. And these are some of the wider projects that we are doing. This one is for the Department of Strategy and Evaluation of BMA. We use the urban monitoring framework under UN Habitat to use to analyze 77 factors in 5 domains and see what's the gap in each domain, like in healthcare or in safety. And this can break down into district as well. So this is a tool that is an open source. It's called Urban Common Source, which is online now. So that the governor, for example, or district office director can use it to see what's the issues, what are the thing they can do to make it's better in terms of policy. This one is more like healthcare distribution. We are like in trying to work with the National Health Security Office to help redesign the way we distribute primary and secondary and tertiary healthcare unit using data both from population, work from the health rights, the universal healthcare card, as well as the hospital area that connect to the main infrastructure throughout BMA. And last 2 things, now it's COVID PM 2.5 season. Now we are working with Clean Air Fund and they are the funding who want to promote Breeze City. They're working with Bloomberg Philanthropy. So right now we are working with them to do participatory governance, clean air governance. So we're gonna use the health data from the 69 health centers to combine with the air pollution data. So we find correlation between the health outcome of the vulnerable population in all of the district of Bangkok. So we can see really like scientifically with evidence that throughout the year, during specific times, specific season, in specific district, what's the impact of that? And from that database that we will build for BMA, which is called AHQI, and health quality index for BMA to use. From that, we will help BMA do the participatory budgeting to use that data, work with the local network to secure funding of around 200,000 baht so that they can do mitigation, maybe like clean classroom, protected classroom, for example, for the vulnerable area. And lastly, this is what we are doing with Thai Health Promotional Foundation, or THF. We are using a social determinant for health equity. So we're gonna work because they want to assess what are the impact of different public policy and research program on particular type of vulnerable population. So we are building this tool using social determinant to see what are the social that factor, socioeconomic factor that determine the health outcome. We also build a tool to help assess the intermediate outcome and help long-term health outcome in the specific target group for them as well. To conclude, I think I'm a bit over time. This is what we learned for the past 5 years and 6 years with good framework, data combining with context, it can help us generate insight. From those insights, if we can align with different stakeholders, it can lead to action. Action with the partnership with the people, especially local community, I think it can turn it into meaningful impact, both short term and long term. Thank you.